Hello, everyone. This is going to be your attendance link. If you're watching this on a recording, go ahead and sign in so we can get a good head count for our sessions this semester. Then I'll come back to this later. So if you miss it, it's okay. All right, assessment and procedures. These are all of your kind of tests that are being done on both the mother and the baby that will be done throughout the course of pregnancy. This stuff is actually really important for your prep assignment that you'll be turning into Professor Harrell in a few weeks. What I would recommend is just to watch this video and to comprehend the material a little bit more, maybe to type out everything that we're going over or to write it out to the best of your ability, okay? It may take a while, but it's worth it. Okay, first concepts. We're going to be going over rupturing membranes. So we're going to end up just saying ROM, SRM. So RM, rupturing membranes, is something that can occur spontaneously or artificially. It doesn't always happen before the onset of labor. As an example, guys, this is whenever we're talking about, their water breaking, okay? So this occurs about 80% of women will go into spontaneous labor within 24 hours. If labor does not begin, there's a high risk of infection because that kind of barrier to anything that can go in is broken now. So we have to be careful, making sure you're not doing too many examinations, things like that. Induced labor if pregnancy is near term. For an SROM, this is spontaneous. This happens at the height of an intense contraction, followed by a gush of blood. If engagement has not occurred by this time, we have risk of a cord prolapse. With an AROM, artificial rupturing membranes, this also can be called an amniotomy. This is going to be performed by either the midwife or the physician. And we'll go into it later where we're talking about how that actually is done. Okay, with a PROM, premature rupture membranes, this is a leakage of membrane fluid before the onset of labor and any gestational age. Okay, lacerations. If they at all, have a laceration during their time of pregnancy, we have different degrees here. I would say just kind of make it into one word kind of definitions for you. So if you just want to go with first degree epidermis, second degree dermis, muscle fascia, third degree, put anal sphincter, fourth degree, and then rectal mucosa. Okay. We have different pain management for the actual process of labor. Instead of going through all of these, I would just say type them out yourself. Know the difference between the two, okay? And then know kind of the disadvantages, really know those. A lot of these are going to cause hypotension. Knowing what we're doing when it comes to a spinal and an epidural, that can actually cause a headache. They get like a spinal headache, things like that. And then what determines what we use for these pain management, it depends what we are doing in the actual labor process and how the baby's doing. Just kind of a straight definition pulled from the PowerPoint slides. The spinal anesthesia is a anesthetic directed into the spinal fluid in the spinal canal to provide anesthesia for a C-section and occasionally a vaginal birth. And then an epidural is in that epidural space, okay? This provides pain relief during labor and delivery. And then we have a pudendal anesthesia. This is administered transvaginally and intercepts the pudendal nerve. This provides pain relief for an episiotomy and delivery. Okay, we're going into prenatal blood work. We have a table right here. This is kind of just something that brings it all together. I really wouldn't say that this is the kind of the main thing. We're going to take them one by one, so it'll be kind of easy to understand, okay? But recognize that these do have different weeks that they are kind of performed. We have them on the slides for you, so that'll be a little bit easier. But whenever it comes to studying this material, really understanding what is diagnostic, what is not. Also understanding that these kind of can go hand in hand with each other. So, understanding that one is 10 to 13 weeks, one is 9, we're going to go with them each at a time. So you'll be able to see that. Already an HCG test. This is of course, our pregnancy hormone here. Presence of pregnancy, making sure that they're viable, checking on our placental health. Okay. Whenever we're going to perform this test, if they have a suspected pregnancy, if they have a history of spontaneous abortions, maybe there's an ectopic pregnancy, because remember with the ectopic pregnancy, guys, that HCG is to the moon. If they're having vaginal bleeding, if they're having conception with assistance. The method for this, we're looking at their blood serum, we're doing a urine analysis, we're doing 2 values drawn 48 hours apart in the second. Okay, they're either going to be positive or negative, and increase or decrease. To interpret this, the doubling of the 2 values indicate viability. Levels that remain stable or fall suggest a miscarriage or ectopic pregnancy. All right, risks, of course, infection. Low risks in the mother and the baby to abstain this test. Waiting between tests can be a very anxious time. MSAFP, maternal serum alpha fetal protein, also called a quad screen. The real big thing here, this is taken between 15 and 21 weeks. We're looking at if there's any risk of an affected fetus, whether it be a genetics-wise or a neural tube defect. Okay, but we're looking at this is really offered for all of women, but it's really recommended for high-risk moms. Okay, the results are either going to be normal or abnormal. If that AFP value is high, we have a risk of a neural tube defect, maybe a multiple gestation. If that value is low, we have a risk for Down syndrome, high HCG, inhibin A, and low UE, unconjugated estriol, risk for Down syndrome. There is a low risk to obtain this test. Alrighty, for the cell-free DNA, this is another genetic test here. This is performed at 10 weeks. So right away, you can see that this is before the last one here. Indications for this, advanced maternal age, because we know that is a risk for having genetic diseases. We're doing, if at all, there was an ultrasound abnormality, if they have a previous fetus with an aneuploidy, whatever that is. I'm not really sure if that's something you need to know, but with our method, this is, of course, obtained through the blood at 10 weeks. This is going to be either positive or negative. Negative being that it's unlikely for trisomy 13, 18, 21. A positive indicates a risk of abnormality. And we really say risk, you guys, because this is not diagnostic. If we have an abnormal result, this is indicating that we need further testing performed. There is a risk for false positive, a false positive, I'm sorry. We have a low risk for infection. This is not screened for that neural tube defect. So really recognize the difference between the two right there, between the Maternal Serum alpha fetal protein and the cell-free DNA. This one's very expensive. Going into more genetic tests, we have the CVS, chronic villi sampling. We're looking here if there's, this is a genetic test, metabolic and DNA abnormalities. Indications again, advanced maternal age, if they have a previous child with any abnormality, or if their parent is a carrier of any of these disorders. We're looking at a small sample of their chronic villi from the edge of the developing placenta. I'm sorry, I had coffee. Placenta at 10 to 13 weeks. So please write that stuff down right there. Results recognize normal is no signs. So negative, no. Abnormal results resulting generally from taken 7 to 14 days. This one is a diagnostic test because it's taken directly from the placenta, okay? So please write that down. Abnormal can detect Down syndrome, Tay-Sachs, and that word right there. Risks for this could be, we'd have some risks now. This can cause a spontaneous abortion, but a very low percentage, okay? Fetal limb defect, failure to return tissue or rupture of membranes, maybe a leak of amniotic fluid. They could have some occasional spotting or bleeding as well. Amniocentesis for karyotyping. Same indications, kind of this purpose could be a little different, because with this we can kind of assess their health or maturity, okay, specifically with the lungs. This needle is inserted into the uterine cavity, and we're only getting that AF of amniotic fluid, okay. This is done at 15 to 21 weeks. This is either going to be, if it's normal, no genetic abnormality. If there's an abnormal effect, we could have some chromosomal issues, maybe birth defects affecting their spine or the brain. And then we do have some risks involved there, so I'd go and write those down as well. We have fetal heart monitor tests. Some of these we've already kind of discussed, but for the sake of really just having them on your sheets for your exam prep, this is really important. All right, we do have our NST, the non-stress test. We're looking at that fetal heart rate. We're looking if there's any decreased movement. Maybe if there's any, for indication, they might have high blood pressure, maybe uncontrolled glucose levels. If they are having a small baby, through looking at from their ultrasound, if there's maybe multiples, or if they're just a high risk pregnancy, okay. We're looking at those contractions and heart rate using a belt monitor, and this was performed at 23 to 24 weeks. Reactive or non-reactive, this is non-diagnostic, okay. The criteria for a reactive test would be 2 accelerations in 20 minutes that measure 15 by 15, and this is a low-risk, non-invasive test. Next is going to be our CST, the contraction stress test. This is really, we're trying to evaluate those oxygen levels during a contraction, okay? Or trying to see if that placenta is stable for both of these fellows here. For the method, we're needing those uterine contractions. We are going to be giving a little small dose of Pitocin, guys, because those can kind of get those things kicking off there. 15-minute recording of the activity and the fetal heart rate baseline. The goal is to have 3 good contractions lasting 40 to 60 seconds in 10 minutes, performed after 23 to 24 weeks. Recognize that negative is normal and positive for this is abnormal, meaning that they did have some late decels occurring. A negative baby heart rate does not decelerate during contractions or have late decels. The risk for this, we have a risk of inducing labor, because remember, we are giving that Pitocin, so there is small risk to that. But we could also have some false positive results, okay? All right, the VAST test. This is kind of a vibration that we're doing to kind of get a fetal response, okay? Indications for this, the usual kind of the hypertension, the diabetic patients, intrauterine growth retardation, post-term, and decreased fetal movement. So we're kind of doing a stimulus to the abdomen of the pregnant woman to get some fetal heart rate accelerations. The presence of the accelerations predict the absence of fetal metabolic acidemia, okay? The results from this could be an increased heart rate, a decreased heart rate, or at all no movement. And for the method, that's would be your interpretation. This is non-invasive and low risk, all performed on the outside of the body. We have some ultrasound-based tests. Of course, we're talking more about like the amniotic fluid. So let's start off with that. The amniotic fluid index, purpose of this, seeing how much fluid is in the body. And the one thing that I think Harold would have already told you by now is that this does reflect kidney perfusion. Recognize the difference between olyhydramnios and polyhydramnios, okay? For an indication for this test would be, hypertension, diabetes, maybe dehydration, preeclampsia, things like that. For the method, we're doing an ultrasound or measuring in centimeters the quadrants of the stomach, splitting by the linea nigra. Our results here are going to be from 8 to 18 centimeters. And we do have a risk of maybe some false results, but I would say that these are still very helpful. The biophysical profile, BPP. Here we have where we're looking at that fetal heart rate acceleration, their breathing, the tone, the amniotic fluid volume, looking at the healthy fetus versus a compromised fetus. Indications of this would be if they're having, at all a decreased fetal movement, maybe they have some intrauterine growth retardation, or if they're having a preterm labor. Gestational diabetes, hypertension, PROM, and the postterm pregnancy. So this is kind of a combination of everything between an ultrasound, a non-stress test, and the CST. We're really evaluating the amniotic fluid, and this is kind of just a kind of a health test here. When it comes to the estimated fetal weight, we're looking at if there's fetal growth occurring, okay? This indication is really based on just risk. If they're, at all maybe going to be a very small baby or a very big baby, we're looking at we're putting 2 belts around the patient's abdomen during an ultrasound wave, and that's where we're getting those results. They should be normal and have a normal heart rate without decels. Interpretation would be, of course, we want to have those no decels, and this is a non-invasive, but it's hard to track if not put in a good spot, okay? It all depends on the fetal lie with this as well. Okay, going into timing of delivery, so really evaluating if we are having a preterm labor or if we're not. So right away is the fetal fibronectin test. We're looking at if there's an absence or a presence of preterm labor. If they have a history of this, then this is really a test we're doing on them. We're going to have a positive or negative test. Negative means the good thing, that the fetal fibronectin is still intact. The positive indicates that we're having preterm labor. I would say that this test is used to kind of interpret if their mom is in preterm labor. The reason it turns that we're kind of swabbing this is because the protein that's there acts as the glue during pregnancy, kind of in that amniotic sac. The fluid filled here is the one that cushions your baby in the uterus to the lining of the uterus. The negative predicts the value is good, the positive is bad, but we could have lots of false positives as well. So that's what we're always doing, kind of further testing, okay? We have the LS ratio here. We're looking at that fetal lung maturity, and if this is not 2-to-1, we're giving that betamethasone, okay? To stimulate that lung maturity, okay? This is kind of evaluating if they're having what's called surfactant here. We have all those indications that could be for a bad placenta here, maybe even resulting in some weak or not matured lungs for our baby. For the risks here, we have diabetic moms have a high risk of false positive, maybe a blood or meconium can indicate a false positive results. Some other tests here, we have the fetal movement counts. These are kind of done at 28 weeks, counting the fetal movements by the mother. An indication for this would be all of our pregnancies. For the method is we want our mother to count the kicks she can feel using the Cardiff count to 10 method. Normal would be 10% of the time they're making movements between 28 and 38 weeks. And after 38 weeks, the movement is increased. If they're at all a less value, then we may have an issue. But really the risk, there's really low risk. Maybe this could be an inaccurate test. They could be sleeping or something like that. Also, when in doubt, have mom come in. If she's calling, always go by what the mother's saying. If she's calling and says, I know my baby and I really haven't felt them today, they can always come in. That's one thing that we would always recommend. Going into the ultrasounds, recognizing the difference between these 3 trimesters of what we're trying to get here. In the first trimester, we're kind of doing fetal age, looking at their defects, the amniotic fluid amount. With the second trimester, we're looking for growth. We're looking for the fetal heart rates, making sure they're maintained. Also looking at their fetal sex, okay? Within the third trimester, we're getting an analysis of our amniotic fluid and making sure it's a stable environment for fetal progression, okay? The results of this, we're always looking at the volume, their sex, possible abnormalities, and maybe some fetal progression as well. Interpretation, recognize the abnormal results versus that can warrant some further testing. Okay, risks, none, smiley face. We have an amnesia here. This is kind of detecting a rupture of membranes. This is whenever our PROM cannot be confirmed by other methods. The method is having a sterile swab inserted into the vagina, detecting the presence of the PAMG1. A risk of this could be infection because remember, once those membranes are ruptured, anything you're doing that's going inside the vagina could warrant an infection later. So you have to be very careful with what you're doing. We have the alternative here. We have the nitrazine paper. The nitrazine paper, if it turns blue with the presence of the amniotic fluid, that means that you are in that actual, I guess, that they are ruptured. You know, it's the real deal type of stuff. The benefits would be this is quick, easy, and accurate. We have nuchal folds. This is kind of the testing if there's any chromosomal disorders. This is performed between 11 weeks and the end of the 13th week. This is kind of a test if there's a history of, if they have a history of any of these chromosomal disorders, or if there's any family history as well. We're looking at the fluid between the posterior cervical spine and the skin on the neck. This is kind of look at in millimeters. More than 33 millimeters is an increased risk of trisomy 21. Risk of this, none, smiley face. Going into our procedures with things that we're doing during the laboring process. Okay, these are all interventions that are performed either by the doctor or by the nurses. Okay, we have our the version, external cephalic version. So if the baby is not all in that cephalic presentation at 38 weeks, they can actually kind of do a little turn the baby in utero. Indication for this is why I'd recommend, please watch last week's video if you haven't watched it. And we have a breech presentation, or we have a transverse lie, or an oblique lie. They're using that what's called the Leopold's maneuver. That is something performed by the doctor where they're kind of feeling around the abdomen, really finding that back. And they're applying pressure to the fetal head and butt so the fetus completes a backward flip or forward roll. This is not done externally. Okay. The benefit would be that this could decrease the risk of a non-vertex birth, or, if at all we're still having that breech presentation, that may warrant a C-section, and we want to prevent that. Okay. For risks of this, we may stress the baby may cause a C-section. The baby could not turn. There's also low risk of having some bleeding occur as well. And lastly, if at all this doesn't work, we're likely going to have a C-section. So that's kind of the alternative. We have two important terms here. These are very important, guys. Augmentation and induction. Now, if anyone here has maybe had a friend who's already had a baby, you may have heard the term, they are inducing her for labor. Okay. That's what I would recommend to remember. Because inducing, we'll start with induction, that is starting labor. This is the stimulation of the uterine contractions before the rupture of membranes, okay? Before the spontaneous onset of labor, with or without the rupture membranes, for the purpose of accomplishing birth. We're starting on a Pitocin infusion, oxytocin as well. That's the same thing, okay? But that's what we're using to start the labor. Augmentation is progressing labor. This is an artificial. You could even match those A's, augmentation, artificial. Stimulation of uterine contractions when the spontaneous contractions have failed to progress labor. This is whenever someone's started contractions, whenever she has, but they're really just not going anywhere, okay? Whenever our cervical dilation or the descent of the fetus have failed. These are all very normal things. These are whenever we're having those really long laboring processes. Okay, so we're just gonna give them some Pitocin, help them out. We also have different methods as well. It's not always Pitocin, but let's go ahead and move into the methods. We have what's called stripping or sweeping. The physician inserts a gloved finger as far as possible into the cervical OS and rotates the finger 360 degrees twice. This motion separates the amniotic membrane lying against the lower uterine segment and inserts OS from the distal part of the lower uterine segment. Okay. As far as that OS where it is, I don't think that's going to be significant for your test. So I don't recall what that is, but it's probably not that important anyway. With the oxytocin infusion, this is very important. Oxytocin is given IV to achieve a desirable labor pattern with strong contractions that will result in cervical dilation and fetal descent. This augmentation is warranted if there are fewer than 3 contractions and a 10-minute period, or if intensity is less than 25 millimeters mercury, as indicated by an internal uterine pressure catheter during the active phase of labor. Also recognizing, guys, that we don't want to have too much contractions. So they're really being careful with this medication here. We have a nipple stimulation, stimulating the release of oxytocin, which in turn stimulates the uterus to contract. This will initiate labor in preventing incidence of post-term gestation and initiates spontaneous labor. We also have sexual intercourse. The female orgasm actually stimulates uterine contractions, and the male ejaculation contains a rich source of natural prostaglandins. Okay, this is a safe thing they can do. This is not used to augment labor. This is only used to induce labor. Okay, this method also promotes endogenous oxytocin, which stimulates those contractions. Of course, we have the stimulants. We have the blue and black cohosh. We have the red raspberry leaves, the acupressure, the acupuncture. Those are definitely could be inducing labor as well. Okay. We also have enemas here. We have castor oil, Calophyllum pustilla. This is as a result of the release of the prostaglandin, consequences of increasing peristalsis and diarrhea after ingestion of the drug. We have some more methods. Primrose oil. This contains a fatty acid, which is converted to the prostaglandin compound. And this is, of course, used after those 38 weeks of pregnancy. Okay. We have prostaglandin gels, Cervidil and Prepidil. These are placed in the vagina and is left needed. It is left in a place to provide a slow release of those prostaglandins. They're easy to use and associated with the need for less oxytocin during labor. Cervidil is also easily removed if the uterine hyperstimulation occurs. They're both associated with uterine hyperstimulation, non-reassuring fetal heart status, and postpartum hemorrhage. We have Cytotec misoprostol. This is available as a tablet and is inserted into the vagina and can be taken orally or sublingually. Cytotec is a peptic ulcer disease drug. Off-label use is induction of labor. Okay, more effective than oxytocin and prostaglandin agents, and is less costly. This is some cheap stuff. Typically, women deliver within 24 hours. It's associated with lower C-sections. We have a balloon catheter. This provides a safe and effective method for our cervical ripening. The Foley catheter with a 25 to 80 milliliter balloon is passed through the undilated cervix. And then it's inflated. The balloon applies pressure on the internal OS of the cervix and acts to ripen that cervix. Okay. And then, of course, we also have the amniotomy, the artificial rupture of membranes. This is kind of just really we've already kind of talked about this, but the most common procedure performed by our OBs, it's at least 2 centimeters of cervical dilation is needed. This can be performed to induce or augment labor. the amniotomy is less costly than other methods of induction. We have our risks, benefits, and alternatives. The risks are non-reassuring fetal heart rate, hypercontractility, fetal hypoxia, going into the lates. We could also have a rapid labor. If they're having a rapid labor, we may have some lacerations occurring, or maybe a uterine rupture. Okay, and we'll talk about that in a bit with what that uterine rupture is. We may have some benefits as well. This is, of course, getting those contractions going if spontaneous contractions are failing to progress. If they're getting induced, our mothers could even choose the day that they begin their labor. With alternatives, we have nipple stimulation. We have those remedies. We have some positioning. We also have natural birth as well. Alrighty, we have cervical ripening. This is the softening and effacing, also called ripening of the cervix, needed for that dilation of the cervix. These mothers may have an unfavorable cervix, and this is used at or near term when inducing labor. We're using the medication misoprostol, Cytotec, dinoprostone. We're using prostaglandins and also balloon catheters. This is used to kind of ripen that cervix. If we can make that thing kind of effaced, very soft, then we will need less oxytocin later, okay? Also leading to a shorter laboring process. The risks, we could have hyperstimulation of contractions. We could have a postpartum hemorrhage, probably low risk though, and also a uterine rupture. We may also have a non-reassuring fetal status, okay? Alternative, C-section if the cervix is not all ripening, okay? One of my friends actually had to kind of have a C-section because of this. We have an amniotomy. We have the, well, this is actually what we were just talking about a little bit ago, but this is our artificial rupture membranes. This is used to induce or augment labor. Recognize those differences, okay? Method, we have an amni hook inserted into the vagina through the cervix against that membrane, creating a very small tear. The benefit of this is a shorter labor, creating a decreased incidence of a C-section. This also can evaluate our alpha fetal, just amniotic fluid, I'm sorry. Next, we have our risks with this. Remember, guys, anything going in, we could have some infection occurring. So we have a danger of a prolapse cord, if at all that are not engaged yet. We have a fetal injury if the hook, maybe cuts the baby. We have a abruption placenta, placental abruption. That's what that could also be called, or an amniotic fluid embolus. With alternative, of course, but being that this is artificial, the alternative would be just a natural rupture membranes, spontaneous rupture membranes, also called. Alrighty, right here we have our amnio infusion. The purpose of this is to increase the amniotic fluid volume, lowering the pressure of our umbilical cord, increasing the perfusion to the fetus. Our indication for this could be oligohydramnios, which that word is when we're having low amniotic fluid volume. We have meconium dilution, or we have we're wanting to prevent those variable D cells, okay? The method of this was we're doing a volume of warmed, sterile, normal saline or lactated ringers into the uterus through an IUPC. The benefit of this is we could have some less compression, obviously going whenever our preventing some late variable D cells, increased amniotic fluid, lowering that cord compression, preventing meconium aspiration as well. The risks of this could be maybe an umbilical cord prolapse, because remember, when there's lots of amniotic fluid in there, that could be a risk. AFE, also uterine rupture, okay? Alternatives with this would be really nothing. We're having, we could either have some slow contractions, a slow birthing process, or even a C-section as well. Assisted operative delivery. The first thing we're going into, I believe, is episiotomy. So this is a widening of the vaginal opening. This is also used to really prevent some lacerations from occurring. Okay. The indication of this is a macrosomia, which is a big baby. Prima gravida means that their first time being pregnant. Okay. Occiput posterior position. Maybe a use of forceps if they're a white race, or use of forceps, or shoulder dystocia as well. The method of this is we're using a very sharp scissor that has a rounded point just before the birth, with 3 to 4 centimeters of the fetal head is visible during a contraction. The benefit of this is it protects our bladder, makes an easier passage for our fetus. We're having a reduced perineal damage because we're preventing lacerations from occurring at all if that is a risk. We are protecting the vaginal wall as well. Okay. The risk of this would be infection, bleeding, or tear from a past incision. Okay. An alternative would be to just allow the body to tear naturally, and then which really is a laceration. Okay. Alrighty, here we have forceps. This is going to be the assisting birth by kind of providing that traction or rotating the fetus to an occiput anterior position. With the indication of this, we may have a breech presentation. We have some conditions that maybe threaten our mom or fetus, and this can be relieved by the birth. Okay. The method of this is the forceps is placed on the fetal head at the +2 or below position, and the head is rotated to the occiput posterior. We have the middle forceps is used when the position is at that +2 or higher. Sorry. And then rotating that head. Okay. The benefits are a faster birth, less danger to our mom and baby, and kind of creating that more favorable position for delivery. We have some risks here. We have some edema on our head. We have some caput subcutaneum, cephalohematoma, and we'll talk about all of this whenever it comes to the newborn presentation later. We have a low APGAR score. That may be a risk as well. We have some retinal hemorrhages, maybe a corneal abrasion, ocular trauma, or maybe a 3rd or 4th degree laceration from our mother, increasing that bleeding. Okay. Alternative to this could be a vacuum or a C-section as well. Next, we're going to be going into what that vacuum delivery is. Okay. Alrighty, going into our vacuum delivery, the purpose of this would be to assist our fetus by applying suction to the fetal head. An indication for this, if we're having a really long second stage of labor, or if we're having a non-reassuring fetal heart rate. Okay. The method of this is we're having a suction cup placed on the occiput of the fetal head. The pump is creating a negative pressure. The physician then applies traction and assists the baby out while mom pushes during her contractions. The benefits of this is it will assist in our vaginal delivery, kind of avoiding a C-section once again. Risks for this, we could have a scalp injury. We could have some bruising going on. We might have a cephalohematoma. We might have some neonatal jaundice, maybe a fractured clavicle. We could also have, at worst case scenario, maybe Erb's palsy and death as well. Alrighty, going into a C-section here, a cesarean delivery. This is whenever we're having birth through the abdominal and uterine incision. Indications for this, obviously a lot of different things, but these things highlighted here are C-section deliveries for sure. We have placenta previa, cephalopelvic disproportion, CPD, if they're having active herpes lesions, or if they're having umbilical cord prolapse, 10 minutes, 10 minutes to get them out. If at all there's a failure to progress labor, maybe non-reassuring fetal heart status, or birth canal obstruction. Okay, this is a skin incision, either transverse or vertical, or having a uterine incision pulling the baby out. Okay, the benefits of this are it's quick, it's higher chance of safety for the baby. Risk of this, we may have a higher mortality rate than a vaginal birth. We might have some post-op complications and of course infection. Okay. Alternatives are of course the things we just went over: the natural birth, the vacuum, and the forceps. Alrighty, for our cesarean births, we have different types of incisions here. For the abdominal incisions, we have, of course, the transverse and the vertical incision. When it comes to our uterus, though, we have some different types of definitions here. First, we have the lower uterine segment transverse. This is, of course, whenever we're wanting to decrease blood loss, decreasing the chance of a rupture or peritonitis. We're doing a decreased post-op distension and adhesions. This is going to require only a moderate dissection of the bladder. This is easier to repair, although it does take longer. This is limited in size, and this creates a chance of extending laterally into the uterine vessels. Okay. Next is going to be the lower uterine segment vertical incision, also known as a low classic. This is really whenever we're doing a most rapid delivery. Maybe the mother is obese, maybe the baby's big, maybe we're having some preterm fetuses or multiple gestation. Okay, this is indicated in the presence of adhesions from a previous C-section, maybe a transverse lie or an anterior placenta previa. Lastly is the classic incision. Infrequently used now. This is kind of the more thing that was in the past. This is going to result in more blood loss. This is more difficult to repair. This also has a high risk of uterine rupture with later pregnancies, because that upper segment is the most contractile portion of the uterus. Okay, a VBAC is not recommended for that classical incision. In the VBAC, the word, what that means is a vaginal birth after cesarean. Okay, we're going to go straight into that talking, I believe, on the next slide. So let's go. Alrighty, so now we're talking about VBACs, vaginal birth after cesarean. This is giving an opportunity for vaginal birth. An indication of this would be a low transverse uterine incision. Okay, so obviously we're running that transverse cut. We're running no uterine scars or ruptures. The in-house doctor and anesthesia for emergency C-section is also present in case there's. Sorry, all the doggos started barking. So with this, we're running, of course, that low transverse uterine incision. We want to make sure that there's no uterine scars or ruptures, just in case, you know. Really with the methods, we're doing a vaginal delivery with any assistance needed. The benefits of this is we're trying to avoid that C-section. This could be an emotional benefit to certain of those mothers that, you know, feel that they just want to do that. Okay. This is also going to have a decrease in morbidity and costs that may arise from a C-section. Okay. A risk of this would be the uterine rupture, of course. It's important to recognize also that if the mother at all had a classic incision on her C-section, that she will not be doing this. Okay. Kind of just overall concepts here. That uterus is a smooth muscle and has a likelihood of tearing during the pressure of those contractions. When we're talking about the chance of, you know, a uterine rupture, we're talking about the uterus rupturing, okay, not really the skin on the outer side of our body. Alrighty, for neonate stabilization, this will be more on your later exams, but we're just hitting on it slightly. So to kind of have it in your mind, we already hit on this, I believe, last week or a few weeks ago, but the ABGAR, we've already kind of talked about this, but a perfect score is 10. However, a normal score is 9. Why? That's because after cyanosis. So the point usually is taken away from that first appearance. We're usually going to have 1 point there where they're having blue extremities, but that torso is pink and well. Alrighty, so for an initial assessment, I'll just say read through this. This really won't be, well, this kind of just talking about ABGAR here personally, but when it comes to the stabilization, resuscitation, that will be on your later stuff, but right here, just recognize the difference between the heart rates, just to read through to be prepared for later, but we're always going to want to make sure that those blankets are dry, because if they're wet, that's a chance of our heat to escape our baby. If the baby's not breathing after 30 seconds, we're going to start breathing for them. And we're doing we're using an ambu bag, a flow inflating mask with a ventilation rate of 1 to 3. We're doing PPV until the baby is breathing and advanced airway is in place. Alrighty, and now we have some practice questions from the past few weeks of info. I'll go ahead, since this is a recording, and just no one's here right now, I guess we'll go ahead and do, I'll just show the question, let you guys read it, give it a good pause right now. Okay, this is a good question whenever we're discussing true labor versus false labor, okay? So right away, in 3, 2, 1, the answer right here is going to be B. My contractions slow down when I walk around, okay? And I went ahead and included the diagram where we can pull information more from this. This is from y'all's textbook, guys, but really just, this is very important stuff. I promise this will be on your test. So just trying to practice, at all, if that question did kind of stoop you a little bit, to know what to look for next time. All righty, our next question here. I went ahead and only put 3 answer choices to make it a little bit easier, but we're kind of evaluating the different stages of labor. So kind of just getting you ready for questions like this, okay? So if you want to go ahead and pause it. And maybe just write down on your piece of paper next to you or your computer what you think the answer is to kind of test yourself. So going into our answer here, it is going to be C. The rationale that we have is that late in the active phase of labor, contractions become more frequent. They're around every 2 to 5 minutes, and they're increasing in duration from 45 to 60 seconds. That's kind of their range. The woman's discomfort intensifies. She becomes more intense and inwardly focused. She's more absorbed in the seriousness of the laboring process. So that late active phase of the first stage of labor, she's, really getting more agitated. She's like, this is the real stuff. But yeah. Next question here. Again, go ahead and pause it right now and write down whatever answer you're thinking. Alrighty, so the answer is going to be A, the latent phase of the first. There's some really good rationales there. Go ahead and give those a read. I'm going to read just the A for you guys. The latent phase of the first stage of labor involves a dilation of 0 to 3 centimeters, the effacement of 0 to 40%, and the contractions are every 5 to 10 minutes, lasting 30 to 45 seconds. Alrighty. Kind of just a nursing question. what to say. So a woman calls the clinic saying her water just broke. What do you say is most appropriate? Go ahead and pause it if you want to go and give it a good solve by yourself. All right, in 3, 2, 1, I'm going to do the answer. 3, 2, 1. It's going to be B. Come to the clinic for an eval. Why would you want to do this? Because whenever our amniotic sac is rupturing, the barrier to infection is now gone, and there is now danger to the cord. Of course, danger to infection, but also we have a risk of cord prolapse if engagement has not occurred. The others increase the risk of infection and cord prolapse. So this is a question about our fetal heart monitoring strip. Okay. The contraction is from the onset to its highest intensity is referred to as what? Give it a pause. All right, now in 3, 2, 1. This answer is going to be C. This is also referred to as a buildup. The acme, of course, is the peak, and the decrement or relaxation of the uterus is going to be D. Alrighty, last question here. The client states, I think my water just broke. I feel this fluid between my legs. The nurse tests the fluid with nitrazine paper and confirms the membranes have ruptured when the swab turns which color? What color? Go and lock in your answers. May take you a little bit. We talked about this today, but the answer is going to be D, blue. Alrighty, last question here. Blake is caring for a woman during the third stage of labor. Which finding would alert the nurse about the placenta has begun to separate? This is going to be more from last week's stuff, but I would say get in the book if you want to know those clear indications between the different stages. But go ahead and pause it now if you want to go and solve it. And then, all right, you may have unpaused it already. The answer here is going to be C, okay? The sign of placenta separation includes a firm uterus, a change in our uterine shape to a globular ovoid, and a sudden gush of dark red blood from the vaginal opening. So it wouldn't be boggy. The shape would be not discoid, but globular ovoid. And yes. And that's pretty much it. If you'd please go ahead and if you haven't at all, go ahead and do the, just trying to pull it up for you guys. The attendance for this week. Again, you know, we just really appreciate it for y'all that are doing these attendance for us. Quan, I really appreciate it. We want to make sure that we're having the numbers for the cohorts to kind of just evaluate, you know, how effective this is being. So we can keep having this, you know, even whenever you guys graduate, some of you guys will be SI as well. Have a blessed day. And if you have any questions, reach out to me over, of course, email and Facebook Messenger. All right. Thank you.